but I want to make an introduction for a topic that is gaining a lot of attention worldwide, really. I mean, it's a big testament to a lot of issues that are now taboo or have always been taboo. Now they're coming to light. And so I want to introduce our next afternoon session. We're talking busting myths about menopause for women in business. We have Adrian Thompson with Vita Women's Health and Cheryl Fisher with Cheryl Fisher Coaching. They're going to be leading our thoughtful conversation today, so give them a warm round of applause.
To make sure that you stay awake. We can do it. Right? Okay, so this is a fireside chat, and what we're going to do is introduce ourselves briefly, and then Adrian's going to ask me some questions. We're going to chat about a few things, and then we're going to flip it. I'm going to ask her some questions, and then we're going to leave plenty of time at the end for you to ask questions as well. So if you think of questions as we're talking, jot them down, or just make sure you're going to remember, because there will be plenty of time at the end. Okay, so I am Cheryl Fisher. I am a certified life coach, and I'm also the host of Mind Your Midlife podcast, which is where all of this started. And in fact, I actually know Adrian because of someone we both met here at this event last year who connected us. So there's a success story for you.
And then she had me as a guest on her podcast.
Correct. Yes. So I have done many things. I'm a multi-career switcher. I was a teacher for a long time. I have been a corporate trainer. And when I started my own business, I realized that I really didn't know how to start my own business and how to think about big goals and be my own boss and not just be worried all the time. And that's where mindset came from for me. And I just love the power that the way we think, the way we speak to ourselves has over us, because we can change it. And that's where the podcast came from. And then I also do life coaching for women who are feeling kind of stuck as well. And we'll talk about some of that. Go ahead.
My name is Adrian Thompson. I'm a physician assistant. I'm a Menopause Society certified provider, meaning I've taken the test from the Menopause Society, which is kind of our governing body for all things evidence-based guidelines for clinical women's midlife health. I also specialize in medical weight management, so if needed, GLP-1s or other medications, sexual health in women, and menopause after breast cancer, GYN cancers, or surgical menopause for those with high-risk genetic factors like the BRCA1, BRCA2. So as a physician assistant having my own practice, I do collaborate with a doc, but I'm able to diagnose, prescribe medications, order labs, or any diagnostic tests we need. So I started Vita Women's Health to leave corporate medicine so that I can have time with my patients. I let women tell their story. They feel seen, they feel heard, they feel validated, and I get the time to have relationships with my patients. And so it's been very, very nice for me as a clinician, but also for my patients. So yeah, and after listening to the marketing lecture, my goal in 2026 is it's a virtual medical practice, but I hope to have a brick and mortar. So that's my goal.
Okay, so you ready to quiz me?
Okay, I'm ready. So, you coach women in their 40s and 50s. So what is it about this time of life, or this period in women's life, that brings them to a coach?
So my answer to that is everything. If you are now in your 40s and 50s, you're gonna understand what I'm about to say, but if you aren't yet, just hopefully this helps with awareness and being prepared and being ready. So in this midlife phase, you might have kids that are suddenly teenagers or they're out of the house. That's a big adjustment either way. You might have aging parents that are going through, the gamut of things that I've gone through with my mom so far, and there's more parents to come, for us anyway. You might be looking ahead and realizing that you only have 10 years left in your career, really. And oh no, what are we gonna do? Should I retire? When should I retire? Do I have enough money to retire? Do I wanna do something else first? There's so much. And we're gonna hear about this more. You might be tired. You might be feeling a little down. You might be upset that your body seems to be different than it used to be and you're not doing anything different. It's all of that at the same time. That is why people in midlife, women in particular, come to me for coaching. And there's a couple of traps that we tend to fall into. One is that your brain is wired to keep you safe. And so your brain is often going to talk you out of things that feel scary or challenging. And I think we heard about that some this morning, really. Being comfortable with being a little scared is something that can be difficult if you're not aware of what's going on. So that's one trap that we fall into when everything feels hard. And another one is comparison. And we know this, and we probably teach our kids not to compare themselves with people on social media and all that, but we do it too. And we wonder, should I be doing something differently? Should I be farther? How could I do this? It doesn't make sense because they don't do this, and it's everything. So there's your answer.
Absolutely. But around that, one thing I hear a lot from women is this feeling of overwhelm. You said stuck, and I hear overwhelmed. What is it about this midlife that people are just so stuck or overwhelmed that makes it so hard?
Just that list of change, of course. I can see faces. You're feeling it already, but we have a little bit more time also around this age to sort of ponder these things. And the more we ruminate on that and think about it and worry about it, the more that we get ourselves riled up. Potentially we create a very stressful state for our bodies because I don't know what to do about my parents, and I don't know if I want to change my job, and I don't like this boss, but I don't know, am I too old to change my job? And it's a lot. And so the overwhelm is, I don't know how to figure it out, and I don't know which thing to work on first.
How do you prioritize?
Which challenge am I supposed to figure out? And so oftentimes we get into a very stressed state, and your nervous system, if we get into what's called the sympathetic nervous system, it's like the opposite of rest and digest. Your brain is not going to be able to think creatively. And if you're trying to figure out, how am I going to help my parents? How am I going to have a relationship with my adult kids? Am I going to change my job? What am I going to do? Should I start a business? And you can't think creatively because you're in this kind of chronic stressed state. You're going to feel like you are stuck. You don't have any ideas. And so getting out of that is really important.
That's what I was going to ask. So when we're in this riled up state, we're in the fight or flight, and it's so overwhelming, how do we calm ourselves?
I am going to give you some tips, but I'm also going to say, can we just please be kind to ourselves as well? Please be kind to yourself. The things we say to ourselves, you would never say to anyone else in your life, truly. I mean, truly. Even if you're sitting next to someone you don't know, and maybe you might be a little bit more snarky to someone you don't know, you would never say it to a friend. You would never say this stuff to someone else. So we have to learn how to kind of unwind and calm ourselves. And it takes time to figure that out because these are real issues that we're dealing with. And it's not all in your head. You know, there's real stuff going on. And so you want to first just be aware. If you are, we call it fight or flight. There's also freeze or fawn. If you are feeling yourself just suddenly get riled up or just feel like, I can't do anything, or if really people pleasing, catch it, notice it, and even that has power. Your emotions are the key. So one thing I work with clients on is how to recognize what you're feeling right now. Because if I said to you, what emotion are you having right now? You could probably say, happy, sad, mad. But we don't think about empowered, dejected, concerned. There's a lot more emotions that say a lot more things. And if you can learn how to recognize that and pause and just kind of listen to yourself, there's probably a track running in your head that says, I can't believe you did that, I can't believe you did that, I can't believe you did that, I can't believe you did that. No wonder you're feeling upset about something. And sometimes even just catching it will help. But I promise tips, so there's one, just be aware, just be aware. And I have a free resource about that called the Story Cycle on my website if you want to take a look. But I also want to just give you permission to rest. And by rest, I don't mean Netflix, really. I mean, sometimes. I'm not going to tell you not to watch TV. By rest, I mean give your brain a break as well. And so for us in midlife, that usually means finding something that you really like to do, and even better if you're doing it with other people. So Mahjong, there's a reason why Mahjong is a craze. There's a reason. It's fun, it's with other people, and it's really good for your brain. I also took up knitting this year, and that's more of a solo activity, but repetitive motion is also really good for your brain. So find something. Maybe it's walking with your neighbors. It doesn't have to be difficult. You don't have to join a team that competes in something. It can be easy, but that's rest that is healthy for your body and your brain, and it will help your nervous system calm down. And that's, I guess, grandma hobbies. That's my theme, grandma hobbies. But also just catching the words that you're saying and being kind to yourself, because it's not you didn't do anything wrong. This is a period of life that can be tough.
And so I've heard you say a couple times on your podcast, we need to take just a little bit better care of ourselves. What is that, just a little bit?
So it drives me a little bit nuts when people say, oh, here's the 10 things you need to do every morning and then your day will be great. And here's the 15 habits you need before you go to bed. And I'm like, I don't want that. I don't want 10 things in the morning. It's too much. I already have too much. So just a little bit better care of yourself is a way of saying, maybe our bodies aren't quite as quick as they used to be. And maybe there really are physical changes that we need to get used to. And maybe there are challenging things in life, but you can do little things that make a difference. You can drink a little bit more water. You can eat a little bit more protein. But please hear me, don't stress about how much more protein, just like a little bit. Like, let your food be fuel for what you want to do. Don't stress about the numbers. Don't stress about how much. Just drink a little more water. Eat a little more protein. Find these rest things to do. And my favorite thing, I actually learned this term maybe a year ago, is glimmers. Does anybody know what a glimmer is?
Yeah.
So this is an actual psychological term. It basically means a tiny moment of joy. So if you start to recognize those, you can actually train your brain to notice them more often. And what a cool concept to go through your day just going, ooh, ooh, ooh. Look, the sun is almost coming out. Glimmer. Wow, I got the creamer in my coffee exactly right. This tastes really good. Glimmer. I mean, it matters, right? Or you just had a conversation with someone and it went really well. You just take a minute to say, hey, that went really well. That's a glimmer. And you'd be surprised how much that matters when you learn to recognize that.
I even at night sometimes, when I remember, try to think back on my day and find a couple things, like little glimmers that I can remember or are grateful for.
Yeah, absolutely.
So from a mindset perspective, is there anything in midlife that you suggest we avoid?
I've said it, but it's worth saying again. Please avoid constantly criticizing yourself. This period of, you know what, any period of time. Women have challenges all the time, right? It's not just in midlife, any period of time. But in particular, this period of time, there's a lot of challenges. So please notice how you're speaking to yourself and try to speak more kindly. And I would also say avoid trying to do everything on your own. Maybe it's a group of friends that you go to and you talk about this stuff. Maybe it's a professional, like a coach or a therapist or a medical professional. Find the help that you need because there's hard stuff that we have to figure out. And so that segues us over to our medical professional, in fact. All right, ready?
Yeah.
No, go ahead. I didn't mean to interrupt. Go ahead.
I mean, because this is real stuff. It's not in your head. You're not unique. This is a shared experience by many, many women in midlife.
Okay, so the first burning question for you. What in the heck is perimenopause? And do we need some sort of test to know if we have it? And when do we have it? And what does it mean?
So I know perimenopause is kind of a buzzword right now, but it actually is a fairly new term. When I was going to school, we didn't hear about perimenopause. We didn't identify it. So I'll kind of explain to you guys what it is. So the average age of menopause is 52, okay? Menopause is defined by going 12 months without a period. And I know there's a lot of women that are like, well, I have an IUD or I've had an uterine ablation. I get that. There's ways that we can tell. But the average age is 52. You haven't had a period for 12 months. Now, the time before that is called perimenopause. And we know that perimenopause can take 7 to 10 years. So if the average age, yep, not for everybody, and I have friends that have sailed through this time. I'm like, oh, like, you don't have any symptoms? People sail through this, and if you're one of them, great. But some people don't. And so if you think of the average age of 52, that means 42, you could start in perimenopause. But what about somebody like me? I'm 48. I am in menopause. That means I could have started when I'm 38. So don't disregard this if you're in your late 30s, that this could be what's going on. And so you say, well, okay, test my hormones, tell me if I'm in perimenopause. I wish I could. Unfortunately, perimenopause is this ramping down of your ovaries, okay? We're born with a certain amount of eggs. And we lose the eggs even when we're born. All the time we're losing eggs. And so perimenopause is when the rate at which our ovaries don't produce eggs, or the eggs they produce are just not that healthy. And so instead of this nice little decline of our hormones over time until we hit menopause, it's more like a roller coaster because of the rate or the healthy variabilities to our eggs that are being produced. It's like a roller coaster decline of hormones in perimenopause. And so you might hear like perimenopause chaos or the roller coaster or up and down, and that's exactly what it is. They say, you know, if you read the textbook, okay, so when you enter perimenopause, some women get their periods closer together, they might be heavier, and then they go throughout perimenopause, they start to spread out, they get lighter. Great. Some people, it does not happen that way. And so when we think about the roller coaster, it could be super high. Women can get a lot of breast tenderness, they can get a lot of bloating, emotional. It could be really low because the lowers are lower in perimenopause, leading to a lot of those symptoms we think about. Or they can be nice and normal. So if you go into your clinician and say, hey, I really think I'm going through perimenopause, could you check my hormone levels? Well, I guarantee you, they're gonna come back high, low, or normal. How does that help? It doesn't help, right? So your clinician says, oh, your labs look great, you're not in perimenopause. You're like, but I don't feel good, I don't feel like myself. Oh, you'll be fine, you're fine. But it's true, so we can't diagnose it, so how do we diagnose it? First, I'm gonna ask you what your symptoms are. So what are your symptoms? Then I'm gonna ask you, what are your periods doing? And then I'm going to probably order labs. I'm gonna get some labs on you because I want to rule out other things that could be causing your symptoms, right? I don't wanna miss a thyroid disorder. I don't wanna miss crazy sugars. I don't wanna miss a lot of things. And I might order your hormones, but I'm getting them for a baseline, or I'm getting them to make sure there's no outliers. And that's it. And based on that, we diagnose perimenopause. And so, you know, our estrogen, our progesterone, and our testosterone are all produced by our ovaries. Our adrenals produce our testosterone as well. So testosterone is more of a gentle decline with age. It's called age-related. But the estrogen and progesterone that comes from our ovaries, like I said, is a roller coaster decline. And so that's perimenopause.
Okay, so speaking for myself, I had crazy awful periods, not that anyone wants to know that. I had problems sleeping. I had irritability. I had brain fog. I had itchy ears.
Oh.
It's horrible. It's horrible. I had to itch my ears all the time. That's a symptom. There's so many symptoms. So tell us some of the things maybe that we might notice.
So how do we know what's going on? What hormones do we need? I don't know. So I kind of classify them based on the hormone, but of course this is a Venn diagram. But when I think of estrogen deficient symptoms, I think of course, the hot flashes, the night sweats, classic. But there's joint pains, brain fog, like remembering a word or concentration, focus. There's extreme mood changes. Some people call it meno rage or irritability, dry skin, dry eyes, itchy ears, ringing in your ears, heart palpitations, stomach upset, frozen shoulder, Achilles tendonitis. A lot of these are estrogen deficient symptoms. And then when I think of progesterone deficient symptoms, I think more of worsened anxiety, difficulty sleeping, as it works on these GABA receptors in our brain that are kind of our calming centers. And then testosterone, I think of, the classic is low libido. And so testosterone is only evidence-based indicated for women in menopause for low libido. We know it does a ton of other things, but low libido. But there's also difficulty getting through that workout like you used to, difficulty recovering from that workout, just a really extreme fatigue from that. It can be some of the brain fog as well. And so that kind of leads me into maybe what hormones we start with if we're treating with hormones.
Okay, so here's another one, and I'm actually a little bit shocked that neither of us just said this. What about weight gain? That's a symptom.
Of course.
Yeah.
And I forgot to say low libido, which, you know, it intersects between estrogen and testosterone. I have to say that, but weight, okay.
So why are we gaining weight and right here.
Have you noticed, like, the muffin top? Right. Oh, so many women. I'm gaining weight. I'm doing the same things. I'm eating the same. I'm exercising the same. And I'm gaining weight. Or I've gained this weight and I've cut back on these things or increased my exercise and I cannot lose the weight. And now my pants don't fit because it's all right here. So, remember when I was talking about that testosterone decline that kind of goes like this, nice, and then the estrogen's like all over? In perimenopause, the highs can be higher, but the lows are usually lower. And overall, the trend is this lower estrogen. And so there is an imbalance between our estrogen levels now to our testosterone levels now. So a lot of women can get this more predominant testosterone or androgen type symptoms. And so that would be more of the weight in the midline, kind of like men get it. You know, men get more of this abdominal fat than instead of the hips and the thighs, which usually is more the feminine. So it moves more there because our testosterone is imbalanced with our estrogen. Maybe you see those long hairs on your face, or you get some acne that you didn't really have before, or more oily skin. Those are some of those androgenic or testosterone predominant symptoms that we see. Yeah.
Okay, so I feel like we're scaring everyone. Just so you know, both of us are in menopause. I'm 55, you're 48. Like, you're gonna be okay.
You're fine. Knowledge is power, that's why we're here.
But also, hormone therapy is power. And so, what is HRT, hormone replacement therapy, menopause hormone therapy? What hormones are we talking about?
All right, we are talking about estrogen, progesterone, and testosterone, like I mentioned. And one thing that we didn't talk about is the genital urinary syndrome of menopause. And when I was talking about low estrogen symptoms, I totally skipped over this because I thought I was going to talk about it and I forgot. Okay, you know how the skin on our face ages and our skin gets drier, thinner, we get wrinkles, and our skin atrophies, and what's going on? The same thing happens to our vaginal tissues, our vulva tissues, our bladder tissues, and our urethra tissues. And so those tissues atrophy as well. They get drier, a less elastin, a less collagen. We can have pain with sex, vaginal dryness, decreased arousal, difficulty with orgasm, urinary urgency, frequency.
Oh my gosh,
I know, but you have to know these things. You have to know these things. I know you might not have it all, or you might, it's scary, I know, and you're not gonna have all of it, but if I can validate one person's symptoms to know that this is normal and a part of it and it's easily treated, that's why I have to say that.
Yeah.
Sorry.
No, I'm glad you said that. I'm glad you said that. Just lighten the mood a little bit. But tell us about hormone therapy.
Okay, hormone therapy. So hormone therapy gets a bad rap, right? That's right. That's right. So I literally thought I was going crazy. I was like, what is wrong with me? Like, I'm going crazy. What is my mood? Like, I'm sweating. What is this? And HRT was pivotal for me. It really changed my life. Now, I know hormone therapy isn't for everybody, and there are beautiful non-hormonal options out there. So if you're thinking, I can't take hormones, or I don't want to take hormones, there are beautiful non-hormonal options out there. You just have to find a provider who knows this information. So what is HRT? The HRT that we like to use today is what they call bioidentical or biosimilar. That is a marketing term. Bioidentical is a marketing term because estradiol is the estrogen that we make. There are FDA approved, safe, affordable, you get them at your pharmacy, estradiol medication. And so biosimilar just means estradiol, which is the same predominant estrogen we have, and we're just getting out of the trough. We're not getting your levels back to where you were when you were 30. We're just trying to get you out of that trough and treat your symptoms and long-term health. So estradiol now is the main hormone we use. There's other ones out there, mainly conjugated equine estrogen, and we'll talk about that too. That's the old Premarin. And then we're talking about progesterone. So progesterone, there is a biosimilar or bioidentical or similar, the same as what we make, called micronized progesterone. Brand is called Prometrium. It's a very safe, great progesterone, very well tolerated. If you can't, it's not the end all be all. There are other great ones, progestogens out there. So there are synthetic progestogens out there, and that's not a bad thing because some people need them, some people tolerate them better, and it's not a bad thing just because it's synthetic. And testosterone, we have wonderful, not for women, but for men, transdermal topical testosterone therapy. We take the male dose and we dose it down for women to 1/10 of the dose. We take the male product and we dose it down, and it's FDA approved, it's safe, it's cheap, it's easy. So that's the testosterone.
Okay, so let's talk safe. Because I heard you say safe, and yet, depending on what age group you are kind of in, you may have heard for a long time that this was absolutely not safe, and hormone replacement therapy could cause breast cancer, and it was not what you wanted to do. And that is not the case, am I right? Tell us more.
That's not the case. So if you aren't familiar with why we think these things, like why do we think it causes breast cancer? Why do we think it causes blood clots and strokes? Well, it all stems back from a study that started in the late 90s, and it's called the Women's Health Initiative, WHI. $1 billion study, randomized controlled trial. Huge trial. And so the main point of this trial was, if we give women at any age HRT, does it reduce cardiovascular disease? And so these were women who had never been on HRT, and they just gave them HRT. The average age was 63, so that's pretty old. A lot older than our normal cohort we see, because by 63, it's an older cohort, and they weren't the healthiest cohort. There were a lot of obesity, there was a lot of smokers, people, there was no qualifiers for lifestyle. So those risks that we talk about are risks independent of the HRT that they're taking. So what did they do? They took two arms of women. One arm of women did not have a uterus. And if you do not have a uterus and you want to take estrogen, you do not need a progesterone. Progesterone is used in women who have a uterus that want to take estrogen. If you have a uterus and we only give you estrogen and don't counteract it with the progesterone, the lining of the uterus can thicken. And this increases your risk of endometrial hyperplasia, which can lead to endometrial cancer. We know that, we learned that in studies in the 70s and 80s. So they wanted to do a group of women who didn't have to take the progesterone, and then a group of women who did. So this one had a uterus, so they took an estrogen and a progesterone. The estrogen used was a synthetic estrogen, conjugated equine estrogen, same conjugated equine estrogen, but the progesterone was a synthetic progestogen called methylperoxyacetate. Okay, fine. So the study gets going, and in 2002, the arm of women that had a uterus that were on estrogen and progesterone was stopped. And the media got a hold of some information. This was the media, not the researchers. The media got a hold of some information and put it out there, front page, front and center. HRT increases the risk of breast cancer, causes heart disease, or strokes, and blood clots, and heart disease. And so we're like, okay, everybody off HRT. Thousands and thousands of women come off their HRT. But what nobody told you, they didn't stop the estrogen-only arm. The estrogen-only arm went on for another year and a half. And we don't really have an answer for why it was stopped. So what happened was, okay, HRT is bad. No. Well, then researchers started saying, well, is that really true? So they go back and they start really digging into that data. Well, is that really what it says? And so what they found, so they've been researching these ladies still today. They still research these ladies. And so it started in about 2007, and since then there's been many studies. And what they found is, so let's talk about breast cancer. So the arm that they stopped early, the estrogen plus progestogen, what they reported in the media was like a 25% increased risk of breast cancer. That's pretty scary. But in actuality, that was the relative risk, not the absolute risk. And when you look at the absolute risk, it was 0.1%, which is actually not statistically significant. So instead of 4 in 1,000, maybe it was 6 in 1,000. So the actual risk was not even statistically significant. And breast cancer in the estrogen-only arm, well, it actually decreased. It decreased the risk statistically significant by 23% relative risk of breast cancer. And if you take both arms versus the women that had placebo that didn't get HRT, the women that took hormone had a less chance of dying from that breast cancer than the women that didn't. And so there's actually some protective benefits here. So then what is it? Why did this arm have a little bit more? Well, they think it's the progestogen, that synthetic progesterone that they use, that methylperoxyacetate. We don't use that today, okay? We do not use it. Our progestogens are safer. If you've ever been on an oral birth control that had an estrogen and progesterone in it, you've taken a progestogen, because every single one of those progesterones in your birth control are a progestogen. So, but today we have micronized progesterone, which is the same one we make. We have IUDs, which are a beautiful thing. And a lot of our progestogens are safer, okay? Methylperoxyacetate, micronized progesterone in studies has not been shown to increase your risk of breast cancer. So that's the breast cancer thing, you know? And then when we talk about blood clots, so that was a pill. They were taking an oral pill. Well, when you take a pill, it has to pass through your liver. It's called first pass metabolism, and that's where you get the cascade for a blood clot that gets set off. So do you guys hear about today, like the patches and the gels and the creams and the rings? Well, those are transdermal, meaning they absorb through your skin. It doesn't go through your liver. It's not setting off that cascade, and you're not increasing your risk above baseline for a blood clot. So that's the difference between the HRT then, the HRT now, and some of those myths that came out of it. Sorry, that was long. But I had to say that.
We're about to go to questions, but we haven't really talked about, there are other benefits related to heart health and bone health. Am I right about that?
Well, yeah, and nobody talked about the good things that came out of this study. Everyone's like, oh, it's such a bad study. It's actually not. It's a fantastic study, because they are still looking at these women and studying them. And so what are some of the benefits they saw? So if we take the hormone therapy groups, both of them, versus placebo, the women that took hormone therapy had less osteoporosis, less bone fractures. If you're so there's also this, 10-year window or period of time where they say that it's opportunistic to take HRT, and it's true. Not to say that if you're 10 years out, you can't take it, but within 10 years, you get a reduction of cardiovascular disease. If you're 60 to 70, it's kind of a null effect. It was over 70 where it was an issue. They saw a 30% reduction in all-cause mortality. That means dying from anything. Better quality of life, sleeping better, mood, all those kinds of things. They gained less weight, and they had less type 2 diabetes.
So.
There were a lot of benefits.
Okay, well, I already see a hand going up. Look at that. Let's take some questions.